Hello, my name is Fayez Kheir. Today I'm going to discuss about detecting a genomic UIP pattern to improve ILD diagnostic as well as prognostic confidence with Envisia Genomic Classifier. Our learning objectives for today is to review the most updated ATS guidelines regarding idiopathic pulmonary fibrosis as well as progressive pulmonary fibrosis. We will understand how the Envisia Genomic Classifier works and its role in the diagnosis as well as prognosis of ILD patients. And then we'll end up by discussing the application of Envisia Genomic Classifier as a complement to cryobiopsy. So the recent ATS guidelines, as you know, suggests that an MDD approach is important to determine diagnosis. And if a bronchoscopy is needed, then a cryobiopsy should be given to such patients. So contrary to the previous guidelines, now bronchoscopic cryobiopsy might be needed for patients with indeterminate UIP pattern or those with alternative diagnosis, where confident diagnosis cannot be determined based only on clinical factors as well as HRCT. And that approach is preferred over surgical lung biopsy for obvious reasons, as surgical lung biopsy is associated with increased morbidity and worse outcomes in some patients. And also, cryobiopsy might be needed in patients with a probable UIP pattern if a confident IPF diagnosis cannot be determined based on clinical factors or HRCT alone. So in a patient who had a chest HRCT, as we said, indeterminate or alternative UIP, a cryobiopsy is needed. A probable UIP pattern where clinical factors might suggest other than IPF, a cryobiopsy might be needed. So establishing a confident ILD diagnosis might be challenging with radiology and the clinical factors alone. And why is that? Clinical exam and patient history depends on many factors. It depends on the expertise of the historian or physician making the history and the clinical exam. Also nowadays, we know that we have too many patients, and that's why it will depend on the quality of the interview and the physical exam you are doing for the patient and the time restraints that we have it with every patient. Also, histopathological UIP is frequently, unfortunately, undetected on HRCT pattern. We know from different studies before that UIP detection on HRCT alone compared to histopathology is at the best up to 50%, because radiologist interpretation of a different radiographic pattern of fibrosis is really highly variable. And also we know that HRCT will not be able to detect microscopic UIP pattern on patients with early disease. So let's start by having a genomic Envisia classifier overview and the performance data for genomic classifier. So how does it work? You need at least 3 transbronchial biopsies that are collected during a bronchoscopy, whether you are associating that with a cryobiopsy or alone. A transbronchial biopsy and not a cryobiopsy has been validated for Envisia classifier. So you send it in 3 separate tubes. Eventually, these tubes will be combined, and what happens? A single whole transcriptome library from the RNA pooled from these 3 samples will be done and will be generated using RNA sequencing. And in 2 weeks period, the results will come, either a positive for a molecular UIP pattern or a negative for molecular UIP pattern. So Envisia is designed to complement the HRCT and the clinical factors for a more confident IPF diagnosis as well as ILD prognosis. So just to say again, in patients who have indeterminate for UIP or alternative diagnosis, or if you have a probable UIP pattern where clinical factors might sway you out from diagnosing confident IPF, Envisia classifier might be used. And if it's positive for UIP pattern, there is a high likelihood that this patient have a UIP positive pattern, whether it's from an IPF or from another disease or another ILD with a UIP pattern. But if the Envisia is negative for UIP pattern, that will not, it has a lower sensitivity, and thus you need to consider other clinical risk factors to eventually label the patient diagnosis. So with regarding to the ATS guidelines, we published a systematic review for the 4 relevant studies identified. And the aggregate meta-analysis showed that the sensitivity for a genomic classifier to label a UIP pattern is 68% and a specificity of 92%. And we have shown as well that there is a high level of agreement between a UIP pattern on Envisia and eventually a UIP diagnosis, and also a high level of agreement eventually to label these patients as IPF diagnosis. So what is the impact on clinical decision making as well as predicting progression? So this is a prospective randomized decision impact survey that was published recently in the Annals of ATS. And what did they do? They brought 103 board certified pulmonologists, where they took a survey for 5 cases randomly selected from 11 cases from the BRAVE trial. The pulmonologists were have academic as well as community practice background. And these cases were selected. There were patients with undiagnosed ILD. They had Envisia, which is positive for UIP, and all these patients underwent a central MDD that eventually resulted in a final IPF diagnosis. And what did they find out? That the number and the confidence in IPF diagnosis have increased when the physician were given the results of the genomic classifier. And also, there was a high confidence of labeling such patients as IPF diagnosis when the results of the Envisia or genomic classifier were added to the clinical as well as radiographic factors for such patients. And not only that, more physicians were willing to initiate treatments and also were willing to start antifibrotics for such patients by adding the Envisia classifier results to their clinical as well as radiographic factors. So recently, there was a publication in ERJ, and that publication looked at the association of genomic UIP classification as well as 1-year progression in 7 medical centers that has done the Envisia classifier. So they defined the progression as either death or lung transplant or a relative more than or equal to 10% decline in FVC. These patients were a mix across a mixed pattern on HRCT with alternate diagnosis, indeterminate, as well as probable UIP patterns on the HRCT. And what did they find out? That more patients, obviously, with Envisia positive had eventually an IPF diagnosis, and more patients who had Envisia positive were on antifibrotics as compared to immunosuppression. Although overall progression for such patients between genomic classifier positive and genomic classifier negative was not statistically significant, but on the sub-analysis, they found that in patients who had alternate diagnosis on HRCT and in patients with a non-IPF ILD diagnosis, there was statistically significant risk of progression in patients who had a genomic classifier positive as compared to genomic classifier negative. The reason that probably that the overall study did not show a statistically significant progression is because of the probably sample size, where you need a bigger sample size. And also remember that most of these patients are on antifibrotics. And we know that antifibrotics will slow progression. And thus, it might be very difficult to delineate that you have a progression in patients who were already on antifibrotics despite genomic UIP pattern positive on Envisia. So what about Envisia and cryobiopsy? So this is an important study first regarding cryobiopsy. That study came around the same time of the ATS guidelines, and thus it was not published within the guidelines. And why the study is important? This study showed that if a patient underwent lung biopsy, and almost all these patients underwent a transbronchial cryobiopsy, it showed that 1/3 of the patients who had a lung biopsy led to reclassification of cases and increase in confidence of diagnosis, and eventually resulted in a significant change in treatment strategy. The MDD team, following the cryobiopsy, were less inclined to wait and see, were less inclined to prescribe steroids, and were more confident to treat patients with either antifibrotics or immunosuppressant medications, depending on the cryobiopsy. But what it also shows that if patients were labeled as a non-IPF pattern before the biopsy, and then eventually labeled as IPF pattern, they did much worse compared to patients, for example, that they were labeled IPF and eventually the biopsy showed a non-IPF pattern. That means a biopsy is important for treatment, for reclassifications of patients, as well as for prognosis. And also, in the last few years, there is a really movement toward labeling a UIP pneumonia as a standalone diagnostic entity. And why is that important? We know that there is similarities observed in mortality, lung function decline, and eventually treatment if patient has a UIP pattern, whether it's from IPF or whether it's from non-IPF patients. And take, for example, these 4 CAT scans. It's very difficult based on the CAT scan to assess which patient has fibrotic hypersensitivity pneumonitis, which patient has rheumatoid arthritis UIP, which patient has scleroderma UIP, and which patient has IPF. And also, based on the recent cold ice trial, they found out that on a cryobiopsy, if there are some features suggesting a UIP pattern, the odds ratio of having a UIP pattern as compared to surgical lung biopsy is 23.4. And also, a positive genomic classifier on transbronchial biopsy has a specificity of 90% of if you have for presence of a UIP pattern. So a cryobiopsy and a genomic classifier should be regarded to complement each other when the cryobiopsy cannot give you a definite answer, and a genomic classifier can complement that, and eventually, hopefully, we will be able to label a patient as a UIP pattern, and we can start treatment early for such patients and prevent progression. To this effect, recently we have published a study that looked at whether a combination of a cryobiopsy as well as a genomic classifier will increase the confidence of labeling patients as an IPF or a UIP pattern. So what we found out that in using 2 separate multidisciplinary discussions, that the diagnostic confidence after adding genomic classifier, cryobiopsy, have increased the diagnostic confidence of patients being labeled as UIP and eventually being labeled as an IPF diagnosis. So recently we went one step further, and we recently have this manuscript accepted for publication. Our research question was 2. Number 1, we asked what is the association of genomic classifier and lung cryobiopsy on a clinical management decision in patients with fibrotic ILD. And also the other question was, what is the association between Envisia genomic classification and the progression-free survival for such patients? This was a retrospective study in 3 medical centers. And as we said, we assessed the change in management strategy following both genomic classifier and cryobiopsy. And also we evaluated the association between genomic UIP classification and disease progression. But this time we used 2 methods. Number 1, we used the ATS definition of progressive pulmonary fibrosis, which is 2 out of 3 of the following: physiological decline with FVC and or the LCO, radiographic changes, and symptomatic decline. And also we used the second method that was published recently regarding death from any cause, lung transplant, or more than or equal 10% FVC decline. So we had overall 98 patients that were eventually included in the analysis. I want to point out that 9 patients out of the 42 who had a UIP positive on genomic classifier had an indeterminate cryobiopsy. As expected, 78% of patients who had genomic classifier positive eventually were labeled as IPF, as compared to 12% only in genomic classifier negative. So what did we find out? That number one, adding Envisia to a cryobiopsy demonstrated meaningful impact on therapeutic strategy. Remember that 9 out of these 42 patients had indeterminate cryobiopsy. Adding an Envisia classifier with UIP pattern eventually led to change in such patients. So overall, there was a change in management strategy when we combined genomic classifier with cryobiopsy in 76% change in management strategy. There was less decrease in the follow-up without treatment, decrease in immunosuppression given, and increase in the antifibrotics that was given. And the second question, we wanted to assess the progression. When we assess the progression between a UIP pattern positive and a UIP pattern negative on genomic classifier, although there was trend toward decreased progression survival with UIP pattern positive, but it was non-statistically significant. But what we did at a secondary analysis, we grouped 2 patients. One group was a UIP positive pattern on genomic classifier, but these patients did not start on antifibrotics for different reasons. And we compared these patients with genomic classifier negative for UIP pattern. And what we found that in patients who had a genomic UIP pattern positive without antifibrotics, it showed disease progression as compared to UIP negative results with a p-value of 0.053. So how can we incorporate genomic classifier in our clinical diagnosis for such patients? You have a patient who had a fibrotic ILD and don't have a eventual diagnosis. You have a clinical and chest HRCT pattern where you cannot pinpoint if this patient has a UIP pattern or not. If a patient has a probable UIP pattern without clinical or clinical factors that can point us toward a UIP pattern, or if you have a patient with indeterminate UIP or alternate diagnosis, there might be a role with combining a cryobiopsy in genomic classifier and BAL in order eventually to confirm or increase your diagnostic confidence and hopefully lead to change in treatment strategy and probably assess the progression of such patients. So to end up with, who are the patients that are appropriate for that? As we said again, probable UIP, indeterminate alternate diagnosis. You have a further workup and eventually you decided that a biopsy is needed. Then you can combine a cryobiopsy with a genomic classifier, or sometimes in patients who cannot tolerate a cryobiopsy, you might assess for a genomic classifier alone to increase your UIP confidence to assess progression of this patient. And if you have a positive UIP pattern, you can discuss again with the referral physician or with the MDD whether early treatment is needed or whether a very close follow-up for such patients is needed. I will end this presentation now. Thank you very much for listening.